The speakers today have no personal business or financial conflicts of interest to report. So let me introduce Dr. Atcherson. He's an associate professor of audiology in the Department of Audiology and Speech Pathology at UAMS and UALR. I guess that's the easiest way of going there. It's a joint department. He's given over 100 presentations on topics involving auditory rehabilitation, assistive technology, clinical electrophysiology, that's impressive, age-related hearing loss, auditory processing disorders, and health literacy. And he's a friend of the GEC, and we're happy that he's here to do the last of our programs.
Well, let me start with this, and that is I have hearing loss myself. And so when I entertain those questions later, either I'll get it the first time or I'll ask you to repeat it, and then certainly I have to repeat the question again since we are recording this today. So without further ado, we are going to be talking about hearing loss in older adults. And because I have hearing loss, I think I have some sensitivity to this issue. I wasn't actually born with hearing loss. I was diagnosed with hearing loss at age 3, so I learned language before that happened. But as the years went by in a progressive manner, I began to appreciate the difficulties over time. Getting new hearing aids every 4 or 5 years, getting stronger hearing aids, even witnessing the changes in technology from analog hearing aids to digital hearing aids, and then about 13 years ago I ended up getting a cochlear implant. So I've been able to witness all of those changes as well. Everything that I have experienced as a child and as a young adult, I think I still qualify. I'm turning 40 in September. Would absolutely apply to the older adult. We have adults who are in their 90s getting cochlear implants because that means for them improvement in quality of life, at least to the end of their stage of life. So let me start with this. You have all heard of Helen Keller before. She was deaf and she was blind. And through the miraculous work of a speech therapist and a very supportive family, she learned how to communicate, she learned language, and she certainly wasn't separated from the world. But this is a parting quote from her. Blindness separates people from things, but deafness separates people from people. And I think that's really powerful when we don't really think about what it is that hearing loss can do to us. But certainly we have ways to counteract that. So my colleague Bonnie and I today are going to be talking about 2 different aspects of communication. I'll focus on hearing, and she will focus on the voice. But what you'll see as a common thread throughout is we talk about these issues in terms of the model of aging. So we've got primary aging, secondary aging, and tertiary aging. Primary is your typical inevitable changes that happen as a consequence of getting older. Secondary aging is it encompasses the things that we do to ourselves, whether knowingly or unknowingly. So it's your environmental factors, your dietary habits, you smoke, you drink, whatever the case may be. And then tertiary aging are the other things that sometimes we would say is sort of touchy-feely, but it is about your quality of life. And so as we are nearing our end of life, what sort of issues come up as a consequence of aging? So we will try to address all 3 of those in both of our presentations today. I first have to talk to you about what hearing actually is before we can talk about hearing loss. And I like to think of hearing separate from what I call auditory processing. So I'm going to read this word for word and let's process this. Hearing is the sense that obtains information about the world around us using pressure fluctuations in the air, which are sounds, that are produced by vibrating objects. Now, hearing is making sense of the information that's coming in. But what we do with that information is actually auditory processing. Hearing loss is going to be an issue related to hearing. But there are other things that can influence how we process what we hear. Think of your typical cognitive, higher order stuff, attention, memory. Those things are your higher order things that can affect auditory processing. So here's a nice definition for auditory processing. It is what we do with what we hear. Now, I imagine at some point in the next 2 hours, whether you're listening to me or listening to Bonnie, that you'll probably tune out. That happens all the time. You're probably thinking about lunch, or you're thinking about the next task that you need to do today. At some point, you will still be hearing my voice, but you will not be processing what I'm saying. This happens to all of us, okay? So hearing and auditory processing really include all the things involving the ear all the way to the brain. And I like to represent it this way. There's the information processing theory, and there are bottom-up factors and top-down factors. Your bottom-up factors are the things that your ear does for us. It's like being in your car and turning your radio on and changing the settings. Maybe you want a little more bass. You want a little bit more treble. You want to balance your speakers inside of your car. All this stuff is happening fundamentally and principally right there in your ear, literally within a couple of inches of the outside. But that doesn't include the brain. So bottom-up factors will be the ear breaking down sounds into intensity, frequency, phase, so on. But then this stuff has to go up to the brain. And the brain is what's going to do our processing for us. So there are top-down factors. I refer to these as higher order functions. So your state of arousal. Perhaps you came in fresh today, or you came in extremely tired. What about your attention, your working memory, and your linguistic competence? I'm convinced that we all would have an auditory processing deficit if we all got onto a plane and went to China right now. Does anyone here know how to speak Chinese? I certainly don't. So we don't have the auditory processing capacity for Chinese, at least not right off the bat. We can certainly learn. Now, the beauty of this is they work together. So just as I described earlier, you will be in here at some point and you will hear what I'm saying, but you may not be processing what I'm saying. Once you get your attention back on me, then you can start to process. But when we're thinking about aging, what is going on? Is there hearing loss? That would be bottom-up problem. Is there a cognitive problem? That would be top-down. Or is there a combination of the two? And that can certainly happen. We know from the literature that there are quite a few things that can come into play as we get older. These are the inevitable things that can happen to us. For some people, they may have very strong genetics that prevent them from having hearing loss, but for most individuals, there will be hearing loss, whether it's primary aging or secondary aging because of the environment. So when I'm thinking about age-related hearing problems, I'm thinking about speech understanding difficulties. So what are some of the things that happen physiologically that might explain why we have more and more difficulty as we get older? The classic situation is we've all seen that grandmother, that grandfather that can hear a pin drop. This is why grandchildren get away with nothing. But as soon as you go into a very noisy environment, they begin to struggle, more so than a younger adult. Why is that? That's what we're looking at here. So vascular and metabolic changes, neural changes. So the neurons themselves are affected in some way, whether it's the myelins, whether it's synaptic junctions, cognitive changes. But cognitive changes will depend on the vascular and metabolic changes as well as neural changes. But there's one new one that I hadn't really considered until very recently, and it is our brain shrinks as we get older. And this would be no different than having quite a few alcoholic beverages one evening, and your brain is dehydrated. So there is a little bit of shrinking going on. And as we all know, there are certainly effects of having too much alcohol in our system. Now look at the red ovals. These are some behavioral consequences of aging on speech and noise and speech understanding. One is poor temporal processing. The best way that I can describe that is, what are the very small timing changes in the things that we hear that we might not be able to process as well as we did when we were younger? A classic example for me is the difference between ba and da, so B-A and D-A. The difference between those two consonant vowel utterances is the voice onset time. So it's the production of the consonant and the release of the vowel. They differ on the order of milliseconds. Now, we don't just speak in ba and da, do we? We usually have a lot more context. But when you throw noise into the mix, that's where you have trouble resolving those very fine temporal cues. As a consequence of poor temporal processing, you're going to have trouble in noise. And so that's what that last red oval is about. About a year ago, I attended a convention session talking about nutrition and aging and effects on hearing loss. And a study that came out is a very old study that I had never heard about until this one session. The question was posed, is there really such thing as age-related hearing loss? So I'm separating in my mind primary aging, secondary aging. So what we see here from 1996 is sort of an early meta-analysis looking at different studies. But I want to draw your attention to these three graphs. One of these graphs has ages 20 through 29, and that's in the top left-hand corner. There's ages 40 through 49 in the bottom left-hand corner, and then ages 60 and 69 over to the right. The red line comes from a group called the Mobbins. They are in Africa. The green line represents the Wisconsin State Fair. Okay? Now, when you look at the 20 to 29-year-olds, you can see there's a little bit of a difference. Well, what is this graph showing me? It's showing me at the bottom the frequencies that we hear. But on the y-axis, you're looking at their threshold. So the lower the number, the better your threshold, or the better your hearing sensitivity. So as you can see, the Mobbins have better hearing than those in the Wisconsin State Fair. Now, what do we do when we go to a state fair? We eat corn dogs and cotton candy, all the really bad stuff. So I'm thinking dietary, not so good, right? But there's already a difference there between these two groups. When you get to 40 and 49, you should see a larger difference in the higher frequencies. And then finally, when you look at 60 through 69, the gap is even wider. Well, what do Mobbins eat? They eat fresh vegetables and fish and meat, very lean meats, and they are not exposed to all the other secondhand things, smoke, alcohol. They live a pretty clean lifestyle. Now notice the red line does have a little bit of change in the higher frequencies. So what I would argue is there's probably a combination of both. As a consequence of getting older, we will have some hearing loss, even in the best of conditions. So for me as an audiologist, these are the things I think about when primary aging comes to mind: presbycusis and genetics. Genetics will determine a lot of the type of hearing loss that we might have, and even the age at which it kicks in. So you see a lot of family history there. Excessive cerumen. I find that as we get older, we tend to become less active. And by becoming less active, we're talking less. When we talk less, our ear canals are not moving the earwax out of our ears. the way they used to. So if you like talking, you're in good shape. Collapsed ear canals. When we're young, the cartilage in our ears and nose is a lot stiffer. When we get older, the cartilage grows and it breaks down. So one of the consequences of getting older is that your ears will collapse. The one time that really comes into play is when you're using a telephone. You're putting the telephone over your ear, and just by pushing, this meaty portion actually causes the ear to fold on itself. And when it folds on itself, we have this complaint that I can't hear on the telephone that well. So an audiologist should be pushing on that ear during their initial diagnostic examination to find out if that's what's going on. I just mentioned larger and sagging pinnas. Otosclerosis is hardening of the bones inside the middle ear. Tympanosclerosis is the eardrum getting harder and less floppy. Otitis media doesn't happen very often. It's more common in children, but when an adult has it, that needs to be investigated. Vascular issues, eustachian tube atrophy, that's the tube that connects your middle ear space to the back of your throat. If that doesn't work properly, you could run into some issues. And then visual acuity and manual dexterity, I'll be addressing that later. So secondary aging, as I mentioned, is an accompaniment of all the things that we do to ourselves, whether knowingly or unknowingly. So smoking, alcohol, maybe lack of fitness, the types of vocational or recreational activities you're involved in, such as hunting, gardening with power tools, and even the medications that we take. And this picture is actually a real picture of a guy who's 101 years old, who's probably older now. I wonder if he's still living, but he's still smoking and still drinking. But I'm not saying that's what we should be doing. He's an exception to the rule. Okay, so what about the population? This is a snapshot of what the United States looked like in 2005. The numbers are steadily increasing, but the distribution is not. And what you should notice at the top is we've got children 18 and younger, and down at the bottom we have 85 and older. But in the middle segment, that's where most of our population falls, and we've got hearing loss issues. Now in 2005, we started seeing an explosion of smartphones and iPods and all that kind of stuff. And here we are about 10 years later, and already teenagers have noise-induced hearing loss because of listening to high levels of music on their smartphones. So as an audiologist, I call that job security, but it is something that I'm worried about. So there are preventative strategies that we can propose, but that group is here to stay. And notice that this is the mid-stage career. And so we're starting to get a lot more individuals into our offices because they are struggling vocationally. And certainly we find that people are working longer. So we'd like to help them stay in their profession as long as they're willing to. Epidemiology. You're going to have to go back and fix that too. Epidemiology and pathogenesis. So hearing loss is highly associated with aging after age 65. So that's 35% of the population. And we know from many, many, many studies that there are a variety of different ways that hearing loss can be caused. The most common is that top one, sensory hair cell loss. So inside of the inner ear or cochlea, the hair cells are what is most susceptible. The other conditions listed below are far more rare, but when they occur, it can compound the issue. So as I said earlier, old ear canals and cerumen. As we get older, if we don't speak as much, we don't have as much mastication, that can actually prevent the earwax from making its way out of the ear. But on top of that, what else is going on? Well, the epithelial migration itself doesn't work as efficiently as it did before. So there's greater likelihood of having wax impaction. And if we're not careful, if we're not looking at that on a regular basis, you may actually have an earwax plug, and that's the reason you have hearing loss. There's a reduction in the number of ceruminous glands, and the wax itself becomes drier and drier and will tend to stick to the epidermal lining. Combined with thicker and longer hair follicles leads to higher frequency of impaction. So we have all seen this. We find that hair grows where we don't want it to grow. We certainly have seen the very bushy ears in some older men. Now take the drier earwax, the fact that it's not moving out, and the longer hair follicles. What you end up with is a mat. And this is something that the average audiologist is not able to remove on their own. They need to go to an ENT, and they're essentially going to the barber. And they have to have those hair follicles cut in order to get that wax plugged out. Well, what does that actually look like? So if I were to do otoscopy and look inside an older individual's ear, this is what I would see. I would not see an eardrum. I would see this dark brown dried wax, and you can see all that hair in there. When they successfully pull that out, it can be upwards of several centimeters long. That's an earwax plug. So what individuals should we be thinking about? And who's at risk? It's the individuals in assisted living homes. The ones that are in bed, they're not out, they're not socializing, they're not moving, they're not talking, they're probably not eating as much, and they are lying down most of the day. These individuals are at greater risk than the average person. So what does typical presbycusis or age-related hearing loss look like? What I have here is an audiogram with what looks like a sloping hearing loss configuration. So on the left-hand side, you'll have the low frequencies. On the x-axis, we now have the soft tones at the top and loud tones at the bottom. So the closer you are to the top, the better you're hearing. The closer you are to the bottom, the worse you're hearing. And these red circles represent the right ear. I could have put the left ear on here as well, but we'll just stick with one ear. The red line going directly across the entire graph at 0 is the average young adult normal hearing level. They can hear at 0. So that doesn't mean the absence of sound, that just means the softest sound that they can hear. So for someone with presbycusis, in the mild form, they tend to have better hearing in the low frequencies and poorer hearing in the high frequencies. That gray shaded area in the background is called the speech banana. And that speech banana is where the typical sounds of speech fall. So most of your vowels will be low frequency and most of your consonants will be high frequency. When you map someone's thresholds on top of that audiogram, you can see the areas where they can capture speech and the areas where they cannot. So for this particular individual, they can probably hear vowels well, but they can't hear consonants. And so it sounds something like this. My vowels are passing through, but no consonants in it. I said my vowels are passing through, but my consonants are not. Okay? So you hear the robustness and the bass of someone's voice, but everything else drops off. Now this is what happens when you go into noise. Noise typically is low frequency, and I'm talking about going to a cafeteria, going to a gymnasium, going to a restaurant. There's a lot of low frequency noise. Well, their better hearing was in the lower frequencies, but noise is also in the low frequencies. So now you have a double whammy. The noise is actually masking out the best parts of your hearing. And now you can't get either the vowels or the consonants. When we put hearing aids on someone, what we're essentially doing is making the speech banana louder. So now we're trying to get it out of the noise, and we're making it louder than the worst thresholds. So here are a couple simulations that I'd like to show. And I hope that everyone can hear these. I've got a number of different hearing loss configurations that we see in older adults. So here we've got no hearing loss, and we've got moderate presbycusis. And in the middle, we have some noise notches. Noise notches typically occur because of vocational and recreational noise. And mild presbycusis and moderate presbycusis has a slow sloping configuration, but certainly at different levels. So here is quiet, no hearing loss, listening to a passage.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
And now I'm going to play noise, and I apologize, it is a little loud, but that's the effect. If you have normal hearing, you should still be able to hear the passage within the noise.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
This is a visual analogy of how I think someone with normal low frequencies and abnormal high frequencies might hear. Can anyone make sense of what's on this slide? Okay, hearing loss impacts communication in a variety of ways. As you saw in my auditory simulation, the loss of audibility is the most debilitating. It's as if you cut off the world. And when you cut off the world, you really can't communicate, and you're relying much more heavily on visual cues and lip reading. Now, I may have had hearing loss my whole life, but for some odd reason, I've learned to lip read pretty well. I can lip read from the side, but then I encountered some deaf individuals in our community, and they're older than me. They've been doing this a lot longer. They've been deaf since birth, and they can't lip read. So I'm not sure that lip reading is a learned skill. But I was a bit taken aback by that. The loss of frequency resolution would be an example of playing two different adjacent keys on a piano and not being able to tell them apart. We'll now take that and apply it to two different people speaking and not being able to tell which one is speaking. That's a frequency resolution issue. And so you see this arrow. Does anyone know who's in that picture? Abraham Lincoln. I'm showing that for a number of different reasons. One is frequency resolution does sort of cause a blurring effect. So if you can just think about how that blurring effect might appear when you're listening to something, it sounds muffled. But we're such bright human beings that we can listen to an impoverished signal over and over and over and become good at guessing. And you certainly just told me this is Abraham Lincoln. That's amazing. Okay, so we have an opportunity to counteract that. Loss of temporal information, that's the ba and the da situation that I told you about earlier. Loss of binaural hearing skills. When we have hearing loss, the timing in our brainstem doesn't work as well, so we can't always figure out where sound is coming from. But an even more devastating effect is we need good ears, two good ears, to be able to comprehend speech and noise. And so when your ears don't work well, your brainstem can't do its job to separate the noise from the speech. And finally, we've got changing hearing and visual demands. So let me tell you how powerful visual cues can be when you're listening. Without visual cues, as shown in this particular graph, what we have are the number of participants represented by the individual bars going from left to right. But down on the bottom is your word recognition ability. So listening to some words and repeating those words back. The percentage correct, 0, would mean poor performance, And that's on the left-hand side. On the right-hand side would be excellent performance. So what you can see is a clumping of these participants towards the poorer side when they couldn't use their eyes to see the person who was speaking. When you allowed them to see the person who is speaking, notice everybody shifted up in performance. We have all done this, and we know this to be true. But the beauty of this study is that they did it on older individuals. Since we're talking about auditory stuff and visual stuff, we do have to acknowledge that some individuals will have dual sensory impairment, and that's auditory impairment as well as visual impairment. And there aren't hard statistics on this, but we believe that out of all of the older adults, we can have between 9 and 22% who have dual sensory impairment. Chances are they're probably wearing glasses, they may be wearing hearing aids, but sometimes they're not wearing one versus the other until we evaluate that. So vision is necessary for the physical and spatial world, and hearing is necessary for social interaction. And so when you do without one, you might imagine that there's an additive effect that can actually be worse than with either of those two conditions alone. So now I want to tell you a little bit about how we can counteract noise. The thing we really need to do is try to improve the signal that we want to hear. Listening to someone speak, for example. And so you can see from this cartoon, definition of background noise is any auditory disturbance that interferes with what the listener wants to hear. Now usually it's the other way around. It's someone younger who is playing music that the older group can't stand. Well, now we've got just the reverse here. How can you listen to this terrible noise, Grandpa? So the concept I want to introduce you to, if you haven't heard of it before, is signal to noise ratio. The signal is the speech. The noise is the thing that you don't want to hear. And signal to noise ratios can be quantified in positive or negative numbers. If it's positive, the signal is louder than the noise. If it's negative, the noise is louder than the signal. And so you can see the box is representing the noise and the happy face is the speech or the signal. So the bigger the signal to noise ratio with a plus sign, the better. Now let's look at some common signal to noise ratios. So if you are in an urban area, you can have signal to noise ratios of +9 to +14. This is generally where we're most comfortable, at home, in our living room. We generally have very nice signal to noise ratios, and it's easy for us to understand. When we go outside, if other people are talking or there's traffic, there's wind noise, you certainly see a little bit of a drop. Parties, on the other hand, start to get increasingly worse. Classrooms, -7 to +5, this is crazy. But we don't currently know what your average hospital or clinic looks like. I've certainly seen very quiet clinics, and I've certainly seen very noisy clinics. So it's just something to keep in mind. Did you have an adequate signal to noise ratio where you work? So this particular study is one in which they changed the signal to noise ratio. On the left-hand side, you have word intelligibility, so how well you were able to repeat back what you heard. On the right-hand side, it's the perceived listening difficulty. So as you might expect, when we go from left to right in terms of word intelligibility and signal to noise ratio gets worse, you start to see a drop in performance. But what's interesting to me is that you can have a +15 signal to noise ratio and still be able to repeat words. But when you ask those participants how difficult it was, there's a little bit of a difference. And so somewhere around 40 dB with a +15 dB signal to noise ratio, although they were understanding the words, their perceived difficulty was much greater. Now notice we said earlier that in an urban setting, you have +9 to +14 in an urban setting. And here we've got +15 dB signal to noise ratio as a place where things start to get a little muddled. What about the effective distance? I'm seeing here that the older folks are sitting near the front and the younger folks are sitting near the back. No, I'm not going to make that judgment. But interestingly, the effective distance does have an effect. So this was a study done on children. This study needs to be repeated in older individuals. But what I love about this is that they controlled the distance, the level of noise, and reverberation. And reverberation is sounds that are bouncing all over the place. So 20 normal hearing children ages 5 to 7. Normal auditory processing. They presented sentences at 3 different distances. So at 6 feet, without visual cues, they only got 89% correct. And again, these were normal hearing children ages 5 through 7. But when you double the distance and it's now at 12 feet, notice the performance now drops to 55%. When you double it again to 24 feet, it's dropping to 24%. That's just crazy. What is that going to be like for an older individual? What's it going to be like for all of us? So the impact of aging on speech perception is a more effortful type of listening. And what has been shown repeatedly in research is that you need at least a 3 to 5 dB signal to noise ratio boost. How you do that can come in the form of a variety of ways: shortening the distance, turning the noise down, or using an assistive device or hearing aids. So sure enough, as louder better, what we see are these different ogive curves. On the y-axis, you have percent correct, so better performances at the top, worse performances at the bottom. And as you turn the speech sound up in terms of dB, louder, you get to a point where you actually get 100% correct. But there is a difference between young adults and older adults. And if you look closely, the 2 different ogive curves reach their maximum point 10 dB different. You actually need to turn the sound up at least 10 decibels louder for older individuals than younger. And in terms of reverberation, on the left-hand side, we have reverberation alone with no noise, and you can see the green line is the older adult, and the orange line is the younger adult. So better performances at the top, poorer performances at the bottom. When you add reverberation plus noise, which is reflected on the right-hand side, you can see both of those groups are down, but it's still that the younger group is performing better than the older group. So I like to show a visual analogy of noise and reverberation. What you're seeing here is something called a spectrogram, and the phrase is, "the child grabs the toy." And what you see are these strong bands representing the vowels, and you can see scattering of gray areas. Those are the consonants. But what happens when you add noise and reverberation? It looks like a mess. And the beauty of this is that if you were younger, you might still be able to capture the speech. But when you're older, it looks just like this. So here's the difference. Finally, tertiary aging. Tertiary aging, I'm thinking about things like psychosocial functioning. And when we have hearing loss, it has been shown repeatedly that there can be feelings of isolation, depression, loneliness, fear, frustration, and disappointment. When you have those issues and you're feeling pretty bad about yourself, you tend to have poor physical health as well. But the nice thing is that if you can restore hearing, not perfectly, not a cure, but if you can give them back something, you can start to see improvements in their health and their well-being. And that's been demonstrated with hearing aids and cochlear implants. And please be careful, if you do work with older adults with a history of dementia, do they really have dementia or do they have hearing loss? It has been misdiagnosed before. So I have pretty much the same information here that's on the previous slide, but what's new is that over the past couple of years, a physician at Johns Hopkins University's Frank Lin has been studying the effect of hearing loss on the prevention or the slowing of dementia and Alzheimer's. This is something we still can't wrap our heads around. But if you have hearing loss and you have a history, a family history of dementia and Alzheimer's, not being able to hear can actually accelerate that. But being able to hear and being able to comprehend those in your environment can slow that down. So that's something we need to think about. So what are some things that we can all do? We can screen for hearing difficulties. In your packet, you should have a handout, a very short screener, but there's an even simpler way to do that, and I'll show you that in the next slide. But we could all slow down and speak clearly and use conversational repair strategies. What I don't mean is to speak louder and exaggerate your mouth movements. All I mean is to speak clearer. We want to face our patients when we're talking to them. We've all seen that before. I'm not going to pick on any one profession, but you go for an appointment in a health clinic, and how often are they not looking at you when they should be? Consider ways of minimizing noise sources. You can close the door, you can get closer, and I would certainly also ask that you avoid elder speak. And that's just simply talking to someone in a condescending way because they're older and they're not as sharp as they used to be. We should never make that assumption. So in your handout, you should have the Better Hearing Institute Quick Hearing Check, if you'd like to use that. That has been validated on over 2,000 individuals. But if you really don't have time and you're pressed for time, simply asking, do you have hearing loss, has a pretty decent sensitivity. Why aren't we asking that? Now, even in audiology, we run into this. We may diagnose hearing loss, we may tell a patient that they have hearing loss, and then we start going into a 20-minute discussion about all the things that we need to do. Do you have any questions? No. Well, is that a good strategy? Probably not. What we should probably do is make sure that they are actively listening to what we're sharing with them. And so the Ask Me 3 method is a way of ensuring that comprehension has taken place. So they need to be able to answer 3 questions. What is my main problem? Oh, I have hearing loss. You just told me that. What do I need to do? Well, I need to make sure that I wear earplugs so I don't worsen my hearing, but you said something about getting hearing aids. I'm not sure I'm ready for that yet, but I'm open to it. Why is this important for me to do? Well, maybe to improve my quality of life. The teach-back method is something useful when you're demonstrating something. No different from demonstrating how to administer an insulin shot. Have them show you how. With audiology, I can do the same thing. I'm showing you how to put a hearing aid on, change a battery, clean the earwax out of the ear mold. I want you to show me, teach it back to me to ensure that there's comprehension. Again, quick solutions are to have a portable amplifier in your office, and believe it or not, there are smartphone apps that can serve the same function. So if you have a pair of headphones laying around, you can plug those headphones into your phone and use the microphone on your smartphone and hold it closer to your mouth so that the patient can hear you. What do amplifiers do? Well, they help you with signal to noise ratio. And so on the left-hand side, as you increase noise, you can see that the speech is drowning out in the noise. But with an amplifier, you're actually preserving the speech to make it a little easier to hear. We're about to wrap up here, so these are the take-home points. What should you look out for? Frequent need to have things repeated, turning head to one side. That's usually the better ear that they're directing towards you. misunderstandings and bluffing. And bluffing is you've just asked a question and they go, clearly they didn't get that. That was bluffing. Excuses for not hearing or understanding. And for some individuals, you might notice that their speech is changing. I know that my speech doesn't sound normal, but there's a reason for that. If you see an older adult whose speech is changing, it could be because they have hearing loss and they can't monitor their speech, or they could have a voice disorder, which is what Bonnie will be talking about later. I mentioned hearing loss can be mistaken for dementia earlier, but I think the other thing we need to do is to think about the patient support group. It may be the case that caretakers don't know how to manage the hearing aids and change batteries and clean them out for certain patients that might need that type of support. I have a bunch of different resources. The first half of these are specific to Arkansas. And so the Arkansas Vocational Rehabilitation is a place where you can go to seek help to stay in the workforce. They certainly help individuals with disabilities. The Arkansas Telecommunication Access Program provides amplified telephones. They are free to the user. You have to register for it, but it's taxpayer money that's paying for this. And over at UALR, we have the largest technology access center in the state. We have a variety of different assistive technologies, and we provide this as a free service. If you'll just call us, let us know that you're interested in seeing the devices that we have, and we would be happy to show you where you can get one. And with that, I leave you with hearing loss may be an individual's problem, but communication is everyone's problem. Thank you very much.